Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to talk about Adbry, which is an IL-13, and its key role in moderate to severe atopic dermatitis. Our moderator this evening is Dr. Patrick Bruner, who is Associate Professor of Dermatology at the Icahn School of Medicine at Mount Sinai in New York, and Director Cutaneous Lymphoma Clinic at the Kimberly and Eric Waldman Department of Dermatology. Our speaker this evening is Dr. Adrian Rodriguez, who is an advanced research expert at Nashville Skin Comprehensive Dermatology Center. We'd like to thank our supporter, Leo, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're at the end of this webinar, an evaluation will be sent to you. If you could please fill it in and send it back to us, we truly appreciate it. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. Within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, please submit your question using the question chat pane on the right-hand side of your screen. And I wrote a little note there so that you could see exactly where you need to type in your questions. So without further ado, I'm going to pass the floor to Dr. Patrick Bruner.
Thank you so much, and I'm excited to be here at this event tonight. So I'm very excited to moderate this IDEF event. IDEF stands for the International Dermatology Education Foundation, presided by Dr. Leon Kircik. And it is, as you can see, a nonprofit organization that aims to raise awareness and improve dermatologic care all over the world through education. And there's a clear focus on underserved areas. And I'm very happy to introduce our speaker, who is part of a very distinguished faculty of various educational programs, as you can see also on our website. And today the talk will be given by Dr. Adrian Rodriguez, and the topic will be IL-13 and its key role in moderate to severe atopic dermatitis. Dr. Rodriguez joined the Nashville Skin in July 2007, did his Bachelor of Science in Microbiology from the University of California in San Diego in 1994. Then he pursued training at the University of Illinois at Urbana-Champaign, and then joined the medical scholars program with appointments in the Department of Biochemistry and the College of Medicine. He did his residency at Vanderbilt and is an expert on various aspects of cutaneous conditions, and we are very excited to hear about IL-13 and its role in moderate to severe atopic dermatitis.
Thank you, Dr. Bruner, and I also want to thank Dr. Kircik and the International Dermatology Education Foundation, as well as Roxanne this evening. And thank you all for joining and participating in these excellent webinar series. It's an honor and a privilege for me to be with you, as well with our sponsors, Leo, as we're going to discuss IL-13 and its role in moderate to severe atopic dermatitis. And
so if you click right in the middle of the screen, it should, there we go, we're off.
And that's our opening slide on looking at efficacy and safety, which is what we're going to highlight first, and as well as looking at IL-13 specifically and its MOA and its importance in atopic dermatitis. So here are the indications for Adbry tralokinumab, indicated for moderate to severe atopic dermatitis in adult patients whose disease is not adequately controlled with topical prescription therapies or those whose therapies are not advisable. I think one of the things I like to point out is that it can be used with or without topical corticosteroids which in the world of atopic dermatitis, it is rare to have our patients not receive a prescription for a topical therapy to accompany their systemic therapies. Contraindications for Adbry only to its known hypersensitivity or to tralokinumab or any excipients in Adbry. So a very clean contraindication. We will take a look now at their pivotal trials, actually 3 trials, 2 that were monotherapy trials, Extras 1 and 2. Extra 3, very interesting, as we were discussing about in its label, that it includes the use of topical steroids within their label, came about from the information obtained from Extra 3. Extra 1 and 2 were placebo-controlled trials with Adbry at a 600 milligram initial loading dose with subsequent to 300 milligrams every 2 weeks versus the placebo arm. And then we looked at the IGA score as well as the EASI score, EASI 75, at the 16-week mark. After 16 weeks, we enter into the maintenance period where the Extra 1 and 2 studies carried on for 52 weeks. And you can see on the slide the various arms, which included Q2 weeks as well as Q4 weeks, which is an additional indicated dose after the 16 weeks that can be used for your patients. Extra 3, a little bit different, as we mentioned. This was using Adbry 600 milligram loading dose, and then the subsequent 300 milligrams every 2 weeks versus placebo with topical corticosteroids as needed. So patients were provided with 0.1% mometasone cream that they could use throughout this aspect of the study in Extra 3. Finally, after the 52-week period, we have the phase 3 long-term open label extension trial that you see on the right, known as Extend, and we'll look at information in terms of safety and efficacy and some of the information we have up to now on that study as well. The secondary endpoint, which we're going to highlight as well, is reduction in worst daily pruritus. Pruritus, to me, when I'm in clinic, is one of the indicators that I look for an improvement in my patients to see how their therapy and their treatment is progressing and how their disease is doing. So looking at Extra 1, 2, and 3, their baseline characteristics of the patients that were enrolled in the study, median age of 35 years, about just over 58% were male, 41% female. Race was just over 2/3 white, 21% Asian, 6.9% African American, and 3.5% others. This is a very important slide in terms of the baseline disease characteristics. Over 95% of these patients were bio-naive. The mean duration of disease for these patients, when we looked at their age, was 28 years. Their mean BSA of 52%. So these patients are severe atopic dermatitis patients. It was 50% were moderate disease, 50% severe disease. Those were the enrollment criteria for the trials. They had to have either an IGA of 3 or 4. Not surprising, over 64% with previous systemic steroid use. Their median EASI score was 28, and their worst daily pruritus average on a scale of 0 to 10 was an 8. So these patients had severe disease with severe itch with a long duration of disease as well. So a heavy burden when they're enrolling into these studies, and this is the baseline pooling of all 3, Extras 1, 2, and 3. So what about their results in the efficacy of their study? So this table nicely summarizes what we see in Extras 1 and 2. Those are in blue. You see on the far right is Extra 3. Patients achieving EASI 75, 25% of patients in Extra 1, 33% in Extra 2, versus placebo rates of 13 and 10% respectively. Their IGA clear or almost clear scores were 16 and 21% between Extras 1 and 2. And then finally, when we look at Extra 3, again, with the addition of topical mometasone, we see that 56% of patients by week 16 are hitting that EASI 75 score and 38% hitting clear or almost clear. So statistically significant results, really demonstrating the efficacy of Adbry at the 16-week primary endpoint. The secondary endpoint, which is one that I said I like to focus on when I'm assessing my patients in clinic, we see how many of those patients achieved a 4-point reduction from that average that we saw in enrollment of 8, 20% of patients in Extra 1, 25% in Extra 2, 46% in Extra 3, really achieving excellent results in terms of their overall improvement in itch. The monotherapy studies from Extra 1 and 2, and I like to highlight this point when it comes to that secondary endpoint of itch, we start to see the separation immediately after their loading dose. So just after their loading dose, 8.6% of patients are already establishing themselves as having that level of a reduction versus placebo at 3%. So that separation occurs early and it is sustained over time, as we will see. From Extra-3, the data that we have from their usage of 0.1% mometasone, you can see that patients in the placebo arm were using nearly twice as much topical corticosteroid as those patients in the Adbry trial. So 10.7 grams versus 19.8 grams in the last 2 weeks of the initial treatment period. Now, of those patients who use 0 or minimal of this applied TCS over the last 2 weeks, we see those results for the initial treatment period. That was 58% of the patients in Extra-3 versus the placebo of 38% of patients. So really significant results in the usage of topical corticosteroid with Adbry in the Extra-3 study, which gives us our visible results, as you can see here with this patient. Baseline IGA of 4, EASI score of 31.9, with a pruritus itch reported as 8. And at week 16, this individual was an EASI 3.6, which is highly significant, but the IGA score is only a 2. So this is, here we're looking at a patient with visible improvement, but not achieving clear or almost clear as that primary endpoint. They were an EASI 75 success. The worst daily pruritus went down to a 3, but I think that in anyone's clinic, this would be a patient that is happy with their results and happy with their improvement from where they were. So when we looked at the pooled analysis of those patients that achieved EASI 75 as well as clear or almost clear by week 16, how many of those progress on through week 52? And you can see in the Q2 week dosing, 58% of patients that achieved EASI 75 at week 16 maintained that response through week 52. Again, as we had mentioned earlier, Q4 week dosing after the 16-week time period is an option for your patients, and it's one that can be readily employed, especially for those patients that might be needle averse or for whatever reason. But we know that we have that flexibility in dosing with Adbry, that we can use either Q2 weeks or Q4 weeks, and 52% of patients maintain that EASI 75. 45% maintain that clear or almost clear on the right-hand side versus placebo. So we're able to achieve good results, get our patients clear, not only that, but maintain them clear, which I think in the real world arena, that's what we want to see. We want to have a therapy that our patients can respond well to and keep that response. So looking at the combination therapy with Extra-3, we see of those patients who achieved that result at week 16, how many maintained it through that week 32 final endpoint. 92% of patients in the Q2 week dosing hitting and maintaining EASI 75, 90% of those in the Q4 week dosing. And on the clear, almost clear side, you see that 89% of our patients maintained that same level of clearance versus 76% in the Q4 week dosing. So still high numbers and high levels of clear skin, and I'm sure improvement in pruritus for our patients. This is a little bit different. I really like demonstrating and using waterfall plots because aside from the data that we just saw where we're looking at mean and or median data analysis of the population of patients in these studies, waterfall plots really demonstrate what happens to the individuals in the study. And one bar that you'll see will represent one patient. You see we have our EASI 75 line as well our EASI 90 line, and this is from the Q2 week dosing with topical corticosteroid, which is Extra-3. And you can see that by week 4, let's go back one. At week 4, we see really a very large, good number of patients by week 4 are already hitting EASI 75 and a smaller proportion hitting EASI 90. So we start to see significant improvement over time. The yellow, green, and red are patients that were discontinued for various reasons. So focus on the blue. You can see that by week 16, we're capturing more and more patients, over half hitting that EASI 75 as well as more hitting EASI 90. And when we get to week 32, we're just seeing far more patients that are hitting that EASI 75 and EASI 90 bar. So for some patients, it may take a little bit more time, but as long as we continue to see improvement in clinic, I like to encourage my patients that they're doing well. And now we're going to take a look at that open label extension that's still going to demonstrate some more of those results. So when we look at Extend, so Extend is a 5-year single-arm open-label long-term extension trial evaluating safety and efficacy of Adbry in those patients. They were rolling in from either Extra 1 and 2 at various time points, and that efficacy cohort started with 671 patients. 523 entered Extend, and the data cutoff for the 2-year mark was in 2021, and they're continuing to observe these patients moving forward. Here is their baseline characteristics of those patients from the parents trial. So of course they all had to be moderate or severe to enter the study, but at baseline we have patients that were either clear or almost clear, and the majority were mild or clear or almost clear. There were some that were moderate and severe, as there was a time gap between the end of Extras 1 and 2 and when Extend enrolls, as we'll see. Their median EASI score was 26.7 in the parent study, 4.7 in the Extend baseline. So significant improvement in EASI scores for enrollment at Extend. Again, the worst daily pruritus was 7.9 or 8. At the baseline for Extend, that was 5. So this is this number of patients when we look at that median improvement in EASI score. So from Extras 1 and 2, the median improvement in EASI was 88%. There was a gap in time, as mentioned, in terms of enrollment for patients from anywhere from 2 weeks up to 26 weeks. So some of those patients did lose a little bit of efficacy, but you can see that not only are those patients recaptured, but we have an improvement over time, that 3-year period, that 93% patient median improvement in their score. So again, maintaining efficacy over time and maintaining those results for our patients. What about safety when it comes to Adbry? And I think that when you look at the safety data, very, very clean. 4 main points that come out in terms of adverse reactions from the placebo-controlled aspect of the study, reactions occurring in greater than 1% of patients. 4 main items to highlight: upper respiratory tract infections, conjunctivitis that was seen in their study, injection site reactions, and eosinophilia. I like to draw your attention to the bottom where you look at our discontinuation rates that were less than 1% both in the monotherapy as well as the combo trials. And when you look at the data relative to placebo, as reported in greater than 1% of patients in the study, you can see that these results are very comparable. There was some conjunctivitis. I do discuss this with my patients when initiating Adbry, as well as any possible ISRs. But the beauty of it is that we have nothing in terms of laboratory monitoring that we have to do or surveillance for our patients when it comes to Adbry. And this is something that is not necessarily a benefit to me, it is a benefit to my staff because that's less paperwork and less follow-up that they have to do when initiating therapy with Adbry. When we look now at outside of the placebo-controlled period at safety through the 42 months from that open label extension study, you see the rate of adverse events. This is from data taken from the initial treatment period versus Extend on the right, and we see that the rate of those events are comparable between the placebo control here on the left versus what we see in the Extend study through the 42-month trial period. So overall, very low level of mild, moderate, and severe adverse event rate. Discontinuation leading to drug withdrawal is very low in the placebo control phase at 2, and again at 2.4 in the Extend study. So in summary, when it comes to dosing, we start with 4 injections, 600 milligram initial loading dose, and then 300 milligrams every 2 weeks with 2 injections. And again, as I mentioned before, after 16 weeks of treatment, patients under 220 pounds that are clear or almost clear, you can consider dropping them down to a monthly dosing of 300 milligrams. Warnings and precautions with Adbry. Again, hypersensitivity reactions that we saw in the initial phase. We discussed the conjunctivitis and keratitis. Do discuss this with our patients if they were to have any eye issues after starting therapy. Helminth infections, which are relatively rare. Make sure to treat any patient that happen to have a helminth infection. And of course, as we've seen in other biologic agents, the risk of infection with live vaccines. So make sure that your patients have already had their live vaccines administered prior to initiating treatment with Adbry. regarding non-live vaccines, there is limited data available regarding co-administration of Adbry with non-live vaccines. Use in specific populations such as pregnancy and lactation. Some of you may remember that we had the OTIS registry, that's now the mother to baby registry, which is a great ongoing study, and tralokinumab, Adbry, is also participating. So if you were to have any patient that were to become pregnant while on Adbry, encourage you to use this registry as we monitor for any adverse developmental outcomes. Lactation data is unknown, but we do know that maternal IgG is present in breast milk and can pass. Pediatric use, safety and efficacy has not been established yet in our pediatric population. So in summary, we're looking at the first biologic that's specifically targeting and neutralizing IL-13, which we'll go into in a little bit more depth in a moment. We saw significant clearance in itch relief through week 16, but I think more importantly, that itch relief reduction starting as early as week 1, just with the loading dose. And of course, maintenance of lasting disease control from extra 3 at week 32 and from extras 1 and 2 through week 52. And the extend open label extension study giving us over 3 years of safety data as well as efficacy data. And we've looked at that long-term safety through 52 weeks. And of course, as I mentioned before, the flexibility in dosage that you can have either Q2 week or Q4 week after 16 weeks of therapy. So for your bio-naive patients who are uncontrolled with prescription topicals with moderate to severe AD, they deserve to trust their skin with Adbry as demonstrated by the data that we've presented. So let's take a little bit of a closer look at IL-13, its MOA, and how Adbry is important in the clinical outcomes for our patients with moderate to severe atopic dermatitis. So we've already covered this, so I'm going to skip over some of these slides and really focus on IL-13. So we know that atopic dermatitis is characterized by immune system dysregulation, skin barrier dysfunction, the microbiome dysbiosis, and the pruritus. And pruritus is one of the areas that I really like to focus on. Cytokines are both regulatory and effector cytokines, so they can alter, as we know, lymphocyte expansion and profile, as well as carrying out a direct effect. And IL-13 is no exception. It has a direct sensory nerve role that can stimulate that itch-scratch cycle. This leads to the continuing cascade of barrier dysfunction with thymic stromal lymphopoietin, IL-33, IL-25, and other cytokines that are involved in the Th2 cascade that leads to clinical atopic dermatitis. Recruitment of additional Th2 cells as well as the innate Langerhans cells are also implied in atopic dermatitis. We know that IL-13 is overexpressed at higher levels than IL-4 in lesional AD skin, and that it's one of the key cytokines that's going to contribute to disruption of all of these aspects that lead to atopic dermatitis. So when we look at IL-13 mRNA expression, and this is, I think, very important data that demonstrates why IL-13 is such an important target for atopic dermatitis. We see expression in AD patients in non-lesional skin. You can see the increased expression in lesional skin versus what we have on the right in healthy controls. When we look at interleukin-4, we see very low counts of mRNA expression that are not increased between non-lesional or lesional skin. The highlight of this information is that IL-13 expression is detected in 100% of AD lesional samples that were assayed in this study. IL-4 was only detected in 40% of samples. Furthermore, when we look at IL-13 mRNA expression, it correlates with AD clinical disease severity. This is the first time that we have a demonstration of increased molecular expression of a cytokine that leads to increasing disease severity. And the SCORAD, if you are not familiar with SCORAD, SCORAD is another clinical tool that we use in the research arena where we look at a patient's disease severity in atopic dermatitis. When we look at these individuals' SCORAD score versus their mRNA expression profile, you see the increase in mRNA expression relative to atopic dermatitis disease severity. So that is very important when we are treating our patients and considering our therapeutic options for our patients. So what does that mean in the normal version of our expression profiles in terms of cytokines and lymphocytes? And what we have is normal cytokine subset development. So these are looking at patients going from infancy through childhood and adolescence, as well into adults. And you can see that IL-13 has a relative constant expression profile and the normal cytokine subset development. Interferon gamma, highly expressed from Th1 cells, we see over time has increasing expression profiles, as well as when we look at restrictions both on MHC, which is another term for CLAs, as well as CD4 versus CD8 expression profiles in Th1. Interleukin-9 expressed from Th9 cells, you see in early adolescence, they begin to peak through the teen years and settle down into adulthood, as well as the other cytokines over time. When we look at patients with atopic dermatitis, look at what happens to their subset development. They have an overall higher level of IL-13 expression. Again, we actually see a little bit of a lower interferon gamma relative to our normal subset in the pink. IL-9 is also mimicked relatively similarly, but we see this increase as well in regulatory T cells. So again, IL-13 stands out as a highlighted cytokine, as we have seen how important that is in atopic dermatitis. So in summary, IL-13 is not the only, but is one of the key drivers of AD signs and symptoms. We have seen how it plays a role in immune dysregulation and AD pathophysiology, really leading to an increased pro-inflammatory chemokine and cytokine response. The skin barrier dysfunction, where we have differentiation of filaggrin profile expression, loricrin, and other proteins that are involved in the skin barrier are disrupted. We have seen how it has a direct sensory nerve effect on pruritus. And finally, there is the microbiome dysbiosis, which also plays into atopic dermatitis when we look at expression of IL-13. So let's turn my light back on. Sorry about that. So how does Adbry interfere with IL-13 signaling? It is the first FDA-approved biologic that specifically targets and neutralizes IL-13. IL-13 interacts via the IL-4 receptor alpha and IL-13 receptor alpha 1 as a heterodimeric receptor to signal to the intracellular pathways that we know are activated through the JAK-STAT signaling mechanism. But there is also IL-13 receptor alpha 2, which is a recycling receptor. It is sometimes called the decoy receptor, but has an additional role in cytokine expression and regulation. And Adbry therefore inhibits binding of IL-13 to IL-13 receptor alpha 1, as well as blocking any interaction of IL-13 with IL-13 receptor alpha 2. What is unique is if there is any additional IL-13, we can still engage with IL-13 receptor alpha 2, which is important in cycling. At the bottom of this slide, this is probably one of the most highlighted features of Adbry. This is not an immunosuppressant. It is not a steroid. And why this is important is for our patients. We all know that it is not an immunosuppressant or steroid, but this is a reminder that we need to educate our patients about what therapy we are starting them that is not going to be a steroid, that many of them, when they come into our clinics, have repeatedly received IM Kenalog. This medication has no boxed warnings, as we mentioned earlier. There is no requirement for initial lab testing or ongoing lab monitoring, or for females to be on contraception, that it's also included in their PI. So I think that those are all important features that we need to highlight to our patients, especially the fact that we're not giving them an additional steroid injection that so many have received for so long. So I'm not going to go over this, as we discussed this already in terms of the warnings and precautions, and we've seen the adverse reaction rates discussed already as well as its use in specific populations. So next, I'm just going to highlight, these are actually case studies that from my clinic and in my practice that really demonstrate more of the real world efficacy and improvement for our patients in their lives of those that suffer with moderate to severe atopic dermatitis. So this patient, John, as we'll call him, is a 50-year-old male, and he presented after 2 years of really severe pruritus that was primarily on his bilateral lower extremities with really large lichenified papules and plaques. He had been, again, as we mentioned previously, through multiple rounds of topical courses of steroids, lots of IM Kenalog injections, and really was sent to me by his PCP and really was looking for alternative treatment options. So we started him on Adbry. His baseline IgA was 4, BSA of 15%, and by week 11, we're down an IgA of 1, a BSA of 1% with minimal involvement and minimal topical steroid use. These patients in the real world arena, like we saw with Extra 3, were all provided with either topical corticosteroids or similar topical therapies that can be used for our patients with AD. This is one of my 27-year-old African-American female patients who had very severe AD for many years, both encompassing her chest, arms, neck, face, had significant hyperpigmentation, had significant involvement of the periorbital region, was started on Adbry, baseline score of IgA of 3, 10% BSA, was seen at follow-up with an IgA of 1, BSA of 1, very happy, and I can share that this is also a patient that has now been lowered down to the Q monthly dosing with her Adbry and continues to have very good results. This patient is a 44-year-old female. You can see very erythematous inflammatory papules and excoriated plaques around the neck, severe lichenification and thickening on her lower back. And this was a 26-week follow-up photographs that we obtained. She had had many, many years of atopic dermatitis, had not been on any type of systemic therapy. We started her on Adbry with good success. IgA of 4 at baseline, BSA of 30%, post-treatment IgA of 2, and a BSA of 2. And this is probably one of my more severe cases. This gentleman presented to my office after, again, referral from the hospitalist where he had been hospitalized previously for various bouts of atopic dermatitis with secondary impetiginization and cellulitis. When I saw him, he had severe erythema, as you can see, of his bilateral lower extremities coming off of cellulitis and had been on antibiotics. But I really like to focus on his hands and his upper extremities that had really thickened heavy areas of desquamation. And the results at week 8, this patient was ecstatic. He had been started on the typical dosing schedule, kept him on the Q2 week dosing, had a baseline score of 4 with a BSA of 30%, and really just the level of clearance that he had on his arms, has a few residual plaques that still on his legs. And I can tell you that I've recently seen him back in clinic and he is 100% clear and continues on the Q2 week dosing. And this just goes on to show what sort of results you can realistically expect with Adbry and incorporating it into your systemic therapy as a first-line agent for patients with moderate to severe atopic dermatitis. So that just kind of gives us a highlight. I really wanted to emphasize the role of IL-13, which is why I wanted to share with you today that module on the mechanism of action of IL-13 and why it's such an important cytokine in atopic dermatitis, and follow that up with some real-world clinical experience and what the results look like that we can see with our patients on initiation and ongoing treatment therapy with Adbry. So with that, I would love to open this up to any questions or commentary that you may have. Again, I want to, of course, thank Leo for supporting this educational forum, and of course the IDEF, Dr. Bruner, and Dr. Kircik. Thank you all.
So again, if you want to submit a question, use the question chat pane on the right-hand side of your screen. And any additional questions that you might think about after the webinar, you can send them to info@idefeducationalseries.com. So stay tuned also for our next educational series that is going to happen Thursday, October 12th. So we'll open it up to the floor. And
Thank you
Dr.
so much
Bruder, is there any questions?
Thank you so much for this fantastic talk. I think it gave a very, very good insight into that medication, and also the pathophysiology of atopic dermatitis. There are a few questions. There's one question. I think you nicely showed us the role of IL-13. The question is what specifically about IL-13 makes it so critical in the treatment of AD? And I guess the other question goes together with it. There's also IL-4 as a type 2 cytokine. What role do you think IL-4 plays in the skin when treating AD?
Thank you for that. So IL-4 and IL-13 obviously have a lot of homology, and they have a lot of overlapping presence. But the data demonstrates, as we saw, that the level of expression of IL-13 makes it, a much, in my opinion, more significant target that can really lead to normalization of that skin barrier and normalization for our patients with AD. IL-4 is detected, as we saw, but the level of expression that we see in IL-13 is far greater. So in my opinion, having an agent like Adbry that targets the cytokine, and we're not targeting the receptor, but we're actually targeting the signal when that signal is present and necessary for the clinical development of AD, I think makes it a much more appealing target for our patients with atopic dermatitis.
Thank you so much. There is another question. Can you discuss data on dupilumab primary or secondary failure rates of response to Adbry?
Certainly. So there is some limited data on patients that were dupilumab failures that were success stories with Adbry. This is information that I know, but we can get additional information from Leo regarding this. But we do have some limited data available looking at patients that failed dupilumab and were successful in treatment with Adbry.
Okay, then thank you so much. Yeah, so there are also questions about, larger pens and when are pens going to be available. Do you know anything about that?
Again, I think that's something that we can ask the manufacturer. I think that we are going to be seeing a pen in the future, but that's something I don't know.
Mm-hmm. Then
I will add that when it comes to, some folks have questions about the loading dose, but honestly, in my experience, it's somewhat of a non-issue. I have my nursing staff administer 2 injections and the patients administer 2, and it hasn't been much of an issue.
Another question. So concerning helminth infections, right? I mean, did you ever see it, or I mean, it's a theoretical concern,
So
but was it ever a practical concern?
I have had, and in a live setting when we have this conversation on helminth infections, I always ask the room who has, and to date, nobody has raised a hand. Although I did have a patient with a helminth infection, and I'd love to say that I was so smart that I identified it. She had a very unusual eruption and was a frequenter in terms of donating to the American Red Cross. She actually came back with a document from the American Red Cross saying that she had trypanosomiasis and that her blood could not be accepted. And then she asked me if this had anything to do with her rash, and it absolutely did. So that is the only patient that I could address to with a helminth infection, but I have not had anyone with it.
Yeah, me neither. Okay, so how far out data is there for maintenance on Adbry?
So what we just shared today is the 42-week data that we have, but we do have, 42-month data that we have, but they do have additional data that should be coming out soon, again, from the information that we have on the Extend study.
Okay, there's another question. What data do you think is most compelling and impactful to position Adbry as a viable first-line therapy?
So again, focusing on IL-13, number one, that I look at targeting of the cytokine, which is the messenger and not necessarily the receptor. And I don't like the concept of interfering with their receptor that is unoccupied unnecessarily, number one, and that's my professional opinion and knowledge. The other aspect is looking at IL-13 and that direct relationship with disease severity. And finally, what I like to focus on is itch. The patients, in my experience, have tremendous improvement in itch, and atopic dermatitis is a reactive disease state to me of lichenification. So if they still have some areas of lichenification and they're using their topicals, but their itch is improvement, I encourage them to give it time, because as their itch is resolved, the skin will heal and resolve. If I get their hands off of their skin, they're going to do okay.
So when your patients are successfully treated, right, and their skin is clear, many or some, stretch the interval, right? And one question is, any studies looking at even less frequent dosing than Q4 weeks?
Not to my knowledge, but again, I think that's something we can turn to Leo. I can share that I have a significant number of my patients on Q4 week dosing, at least a third of them, and I have not had to go back to Q2 week dosing because they've been able to maintain that level of clearance.
Another question, or lots of questions coming in. What happens to the eosinophilia with treatment?
So there was a transient decrease in eosinophilia that was seen that did not require laboratory monitoring, nor did the FDA feel that that was necessary in terms of prior to initiation of therapy. So that has been seen, and there can be multiple theories as to why we see the changes in eosinophilia, perhaps with eosinophil trafficking, but again, that's something that hasn't required monitoring.
And another question, is the incidence of conjunctivitis the same, less, or more than Dupixent?
So first, we really can't compare trials in that regard because how conjunctivitis is determined can be variable. Aside from infectious conjunctivitis, atopic conjunctivitis, atopic keratoconjunctivitis. So I don't think we can effectively compare them. I can share that in my experience, I have not seen it. It was seen in their studies, albeit at a low level. And as you saw, their discontinuation rates were very, very low in their study.
Right, and there are other questions, right, relating to the same. I guess the answer would be the same. How is it compared to Dupixent for safety and clearance?
Again, we really can't compare the studies. The trial designs are very different, and Adbry was held to a little different rigor, if you will, in terms of their study design, the washout period that they had for their trial, as well as the trial design and setup. So we really can't compare those two. This isn't by any means a knock on Dupixent. It's been an excellent drug for many patients, but when I'm looking at the MOA and what my choices are and the options that we have for our patients, I think Adbry really demonstrates what we can do for our patients and really achieving therapeutic efficacy.
Great. Thanks so much for these answers. So far, I see those were all questions. If you were double questions, I think I covered them. So I think those were the questions. So thank you so much for this great presentation. I think we all learned a lot, and thanks so much for this comprehensive, insight into also pathophysiology of atopic dermatitis. And I greatly enjoyed your talk. Thank you so much.
Thank you, Dr. Brunner. It's been a pleasure. Thank you all for joining this evening.
Thank you, everybody. Thank you for joining us. Good night.